Hi, everyone. Welcome to another episode of Dr. Gilbert Hosts. Today, we have a fascinating topic. We're going to be discussing Alzheimer's disease and how it is similar to and different from Parkinson's disease. So I'm looking forward to that information. It's going to help us really understand where we stand in the world of neurodegenerative diseases. And our special guest is Dr. Claire Sexton of the Alzheimer's Association. So as our usual structure, Dr. Sexton is going to give a brief introduction of the topic, and then you'll be able to ask your own questions. So please get them ready. It's my pleasure to introduce you to Dr. Sexton. Claire Sexton DePhil is Senior Director, Scientific Programs and Outreach at the Alzheimer's Association. And in this role, she developed scientific programming for the Alzheimer's Association International Conference and its associated meetings. And she oversees strategy for the Alzheimer's Association International Society to advance Alzheimer's research and treatment. In addition, Dr. Sexton delivers presentations like the one she's about to give to audiences around the country on the association's role in scientific advancements and the overall state of Alzheimer's and dementia research. Dr. Sexton received her doctoral degree in psychiatry from the University of Oxford. And prior to joining the association, she served as an Atlantic Fellow for Equity in Brain Health at the Global Brain Health Institute. So welcome, Dr. Sexton, and thank you so much for being with us today.
Thank you, Rebecca. It's so lovely to be here with you today and with so many people I can see in the comments from all over the country. So delighted to be here.
Fantastic. So everyone's eager to hear your introduction, so please start us off, and then we'll have our Q&A. So thank you, Dr. Sexton.
Thank you. So as I said, it's a real pleasure to be here with you today and to be talking you through this advancing the science, the latest in Alzheimer's and dementia research. This is a really exciting, it's a really pivotal moment for the field. There is so much going on, and it will be a pleasure to talk you through it in a bit more detail. But to start off, we really wanted just to level set a little bit, because the most common question we still get asked when out and about in our communities is often, what's the difference between Alzheimer's and dementia? So dementia is an umbrella term, and it's used to describe a range of symptoms. So these symptoms can include changes in memory. So this can be difficulty remembering newly learned information. It can be forgetting material that was just read, for example. It can be changes in thinking, so challenges in planning or solving problems, difficulties in concentrating, for example. And there can also be changes in behavior. So this, for example, could reflect changes in mood, apathy, or personality, and sometimes can result in somebody behaving inappropriately socially. Now, in order for a diagnosis of dementia to be made, these types of symptoms, one or more of them, must be severe enough to be interfering with daily life. So, for example, lead to problems keeping appointments, keeping track of monthly bills, affecting an individual's work or their relationships. Now, there are many causes or types of dementia. These include Alzheimer's disease, but also vascular dementia, frontotemporal dementia, dementia with Lewy bodies. Also, mixed dementia is very prevalent. So this is where the symptoms have more than one underlying cause. Now, each type of dementia is unique. It has its own unique set of symptoms, its own unique progression, and also underlying brain changes. If we look to the most common type of dementia, Alzheimer's disease, this is characterized by three main hallmarks. These are the buildup of amyloid plaques in the brain, which are made up of the protein beta amyloid, tau tangles, made up of the protein tau, and then also there's cell death. So you can see this in this illustration where there's the shrinkage of the brain and neurodegeneration with Alzheimer's disease. So these are three key hallmarks, but there are further changes in the brain still. And today, then, I want to take you on a whistle-stop tour to look behind some of the headlines that we've seen, particularly in relation to Alzheimer's disease. And these have all, grabbed headlines in the past year or 2 years. So it's all recent advances. So these span anti-amyloid therapies, also the therapeutic landscape as a whole, as well as advances we're seeing in terms of earlier and more accurate diagnosis and the introduction of further biomarkers. Then finally, I'll speak a little bit about some of the headlines in terms of modifiable factors. But where else could we start but this new era we've now entered for treatments for Alzheimer's with anti-amyloid therapies? And this was the first headline I'd like to share with you. So this was back in October 2022, so about 18 months ago. And this was published on our blog, and it was written by our Chief Science Officer, Dr. Maria Carrillo. And it was entitled, "Positive Treatment Data, Lecanemab Brings Hope and Enthusiasm." What a great headline for us to be seeing. And it opened with the statement that we are living in historic times for Alzheimer's. And it was written in response to the first release of results anywhere in the world of the phase 3 Clarity AD clinical trial of lecanemab. So lecanemab is an anti-amyloid therapy. So it acts to reduce the presence of amyloid in the brain, and amyloid being one of the key hallmarks of Alzheimer's disease, as we've just discussed. So this study recruited just shy of 1,800 individuals with early Alzheimer's and confirmed presence of amyloid. And then the results of brain scans showed that over the course of 18 months, lecanemab was extremely effective in reducing amyloid in the brain, to such an extent that for the group who received lecanemab, the average level of amyloid seen on brain scans at the end of the trial no longer passed the threshold of being considered amyloid positive. So this is remarkable. In addition, lecanemab was also shown to reduce clinical decline compared with placebo by 27%. Now, what does 27% equate to? So this can mean that decline in cognition and functioning, which is typically seen over the course of 18 months, may instead take place over something of the order of 22, 24 months. So then it can give individuals and their families an extra 5-6 months longer in the early stages of disease. And as somebody with family members living with this disease, those types of extra months in the early stages would be invaluable. Now, it's important to note here that there's a number of caveats. These anti-amyloid therapies do not represent a cure for Alzheimer's disease. They do not halt completely, or do not reverse the decline in cognition or functioning that occurs with Alzheimer's. Also, responses vary between individuals. This is the same with any treatment. And then finally, there are side effects that the individual and their family should discuss with their doctor before any decisions regarding treatment are made. But having a treatment that changes the course of Alzheimer's disease in a meaningful way for people in the early stages of the disease is just so welcome. You know, this is a first for the field. This is a first where we have treatments that are addressing the underlying biology of the disease. Now, since this blog was first published, 18 months ago or so, we've learned even more about the results of this trial. And they've been published in full in the New England Journal of Medicine. And then in June last year, lecanemab was approved by the FDA, and it's being prescribed across the country now. Lecanemab is not the only anti-amyloid therapy, though. So donanemab is another therapy, and similarly an anti-amyloid therapy. And we heard then in May 2023, so a year ago, the top-line results of a trial of donanemab. And this stated that donanemab slowed clinical decline by 35% compared to placebo. And it resulted in 40% less decline in the ability to perform activities of daily living. So another positive trial. And this trial then was interesting because it also showed that and indicated that there'd be greater benefit when started earlier in the disease course. And also there's a novel aspect of this treatment, which is then there'd be limited duration of treatment. So people had repeat assessments of amyloid, and then once it was shown that there was a certain level of amyloid clearance in the brain, treatment was stopped. So then people could be on this treatment for 12 months or 18 months and then pause in from treatment. So donanemab then has been submitted for review for the FDA, and then we'll be hearing more about its approval process in the coming months. Now, right at the start, before these trials were, releasing all of their results, and while we were finding out more about them, the association was taking a future look, and in August 2022 launched ALZnet. And this is a long-term data collection and sharing network for new treatments. So ALZnet aim is to gather real-world clinical practice data and outcomes. So this includes treatment effectiveness and side effects. And ALZnet will include people from a variety of backgrounds and communities to achieve representation beyond the populations historically enrolled in clinical trials. So then this is vital to be kind of continuing to monitor these treatments as they get rolled out within our communities. So that brings you up to speed with the latest on anti-amyloid therapies, but the landscape for the therapeutic landscape as a whole is far, far broader than just anti-amyloid therapies. So there are currently then 164 trials assessing 127 drugs for the treatment of Alzheimer's disease. And these target not only amyloid, but also tau, cellular communication, neurotransmitters, vascular stress, neuroinflammation. So a multitude of different targets. And what's exciting about this, and what these anti-amyloid therapies have opened the door to, is then other drugs being developed, and then there being combinations of therapies. So not just targeting amyloid, but targeting tau as well. And already underway today is a trial which is administering both an anti-amyloid therapy and an anti-tau therapy. So having this combination. This is then one of the key elements that we'll see going forward, that there'll be combinations of therapies and also personalization of therapies as well. So this will mean that maybe somebody would be on certain treatments at an early stage of the disease and different treatments at a later stage of the disease. And the different types of treatments may differ from person to person. And this is the type of approach, this personalized approach, this combination approach, that we've seen to be successful in other fields, for example, in treatment of cancer. Another key area that this field is headed in terms of this therapeutic landscape as a whole is towards even earlier intervention. So there's trials underway using these anti-amyloid therapies, but to be looking at before the emergence of symptoms. So we know that these amyloid plaques in the brain, they don't just develop at the same time concurrently with the development of symptoms, but these amyloid plaques in the brain can build up, 5, 10, 15, even 20 years before somebody receives a diagnosis. So are we able to intervene with these treatments in this window of opportunity, reduce the amyloid of presence of amyloid in the brain, and then potentially delay onset of symptoms? This is a tantalizing proposal, and it's one that's currently being examined by studies today. So we'll be hearing results of those types of trials in the coming years. They take a lot of time, a lot of work to be going on, but they are underway. Now, for all of these types of treatments, and for somebody to benefit from a treatment, somebody must first receive the right diagnosis. And biomarkers are key in terms of having the right diagnosis. So for nearly 100 years, the only way that we knew if somebody had those amyloid plaques and tau tangles that are, two of the key hallmarks of Alzheimer's disease, was in post-mortem studies. So this limited the success of early trials, because we didn't know for sure that people given anti-amyloid therapies, actually had amyloid in their brains. And in fact, many didn't. Their symptoms had other causes. But now that's all changed. And biomarkers offer a window into the brain, and we can gain measures by a variety of different techniques. So one of these, and we can see the latest headline associated with it, is amyloid PET scans. So in October last year, in 2023, we'll see on the next slide that the Alzheimer's Association applauds the CMS's decision to cover PET imaging for Alzheimer's disease diagnosis. And our chief science officer was sharing how amyloid PET scans are a proven tool and can be an important part of Alzheimer's diagnosis and treatment. And this broader access is positive for our communities. So this then means that we can have an amyloid PET scan, we can visualize where in the brain there is the presence of amyloid, and to be determining if somebody is eligible or suitable for the types of anti-amyloid therapies. Other types of biomarkers are in development, and one of these is the progress in terms of blood tests. So for blood tests, then there's been such rapid progress over the past, 5-10 years. And we're seeing this then as advanced in terms of how the blood tests are being used to ensure that the right people are enrolled in clinical trials, and also they're being used to kind of evaluate the success of these treatments and gain understanding into how these treatments work by being repeated along the course of a clinical trial. In a couple of years ago, in 2022, we had a global work group, which released recommendations about the use of Alzheimer's blood tests, and they shared that blood-based biomarkers for Alzheimer's are already improving the design of clinical trials, and that they are very likely to revolutionize the diagnosis of Alzheimer's in the future. But they caution that much more research is needed before widespread clinical use. This was because then further research was needed in primary care settings, including in representative and diverse populations, examining a variety of tests and potential impact of medical comorbidities, medications, for example. Now, even though this headline only came out in 2022, so not yet 2 years, this work group has been reconvened and then is re-examining this literature to see how much closer we are to the clinic for these types of tests. So progress is rapid. Now, next stop, for the last stop on our headlines, when we're thinking about intervening early and risk reduction, it's not just pharmacological approaches that are important, but also non-pharmacological approaches are also paramount. And here there's been a host of different modifiable factors that have been investigated. So these span our health and the healthcare we receive. So neurological factors like traumatic brain injury, psychiatric factors, vascular factors, sensory factors, sleep, for example. Also expands our environment. So physical environment, such as air pollution, has been looked at. Social activity, the number and the nature of our interactions, economic environment, low socioeconomic status. Also our behavior, so physical, social, cognitive activity, the fuel we put into our bodies in terms of the food, the rest that we get. Now, for all of these types of modifiable factors, there's no guarantees. So it's possible to have a full house of risk factors and not develop dementia. It's also possible to have relatively few risk factors and still develop dementia. So even though these can't give us insights on the individual basis, they are really informative when we're looking at a population level about what factors in general may slightly increase or decrease our risk. And a few years ago in 2020, then there was the release of the Lancet Commission Dementia Prevention, Intervention and Care report, and this stated that modifying 12 risk factors might prevent or delay up to 40% of dementias. So it highlighted all of those factors there and throughout the life course. So as you can see, it's many of those factors that I just mentioned: traumatic brain injury, depression. What's good for your heart is good for your head. So factors like diabetes, hypertension, obesity, smoking, all associated with vascular health, are also associated with dementia. Now, across this literature, then they also highlighted that interventions to prevent cognitive decline or cause dementia or Alzheimer's disease are few. And in terms of interventions, then we sometimes see mixed results when studies are looking at a single risk factor in isolation. And potentially, there's most potential when combining different risk factors. So the final headline then I'd like to share, which came out last year, is that the landmark US Pointer study had completed recruitment of over 2,000 participants, including 30 participants from underrepresented communities. So US Pointer is a 2-year clinical trial, and it's looking at lifestyle interventions. So these lifestyle interventions look at diet, physical activity, social activity as a component as well as management of vascular risk as well. And this study then is 2 years looking at different types of intervention, and it's underway now. So study recruitment was complete, and now there'll be 2 years of collecting the data, and then we'll be reporting out. And I think our ears are all open to be hearing what these latest results will be. So that hopefully gave you a bit of a taster of some of the different headlines that we've seen in the past couple of years spanning anti-amyloid therapies, the therapeutic landscape as a whole, biomarkers, modifiable risk factors, and I'm happy to be taking questions and talking with Dr. Gilbert more about these. But before we do that, I just wanted to share just a couple more bits of information regarding the association's work. So the association the Alzheimer's Association is the leading worldwide voluntary health organization in Alzheimer's and all other dementia care support and research. With regards to our funding, we are the world's largest non-profit funder of Alzheimer's and dementia research. We have $405 million currently active in research funding. This supports over 1,100 projects the world over in 56 different countries. So this is across Europe, in the US, in Latin America, Africa, in Asia, the world over, we're seeing this. And these, I've got a couple of funded projects we'd like to share with you, which just tap into then how these not only support research into Alzheimer's, but also into other types of dementia as well. So then looking at the relevance of novel biomarkers, and then also looking at possible treatments as well. Finally, more information on everything related to Alzheimer's and dementia research will be at our conference at the end of July in Philadelphia. We are having a new component this year, which is called AAIC for All. This is going to be on the final day of the conference, and it is free for any community members to join us. So anybody, anywhere can join us for free for the final day and to enter the AAIC for All community track. And you can hear about some of the research that's going on in Philadelphia. You can hear some of the research highlights, what headlines have come out of the conference, and what the latest is with all of these advances. And then you can also be treated to listening in to the final plenary speakers. So the website for that is als.org/AAIC for all. So please do register if this has whetted your appetite and you'd like to find out more. But for that, I'd just like to thank you and invite Dr. Gilbert back on screen for the discussion.
Am here, but don't know. Can you hear me?
I can hear you, Dr. Gilbert.
Okay, so my camera seems to be on, but I'm not being seen, and I don't know why. So let's keep going. Because we have a lot of questions in the chat that people are really excited to hear your opinion of. So let's get started before we figure out my camera. The first question that has been rocking the chat is, what's the connection to Parkinson's disease? You've talked a lot about Alzheimer's disease. You've talked a lot about therapies and biomarkers. What is the difference between Alzheimer's disease and then the dementia that accompanies Parkinson's disease, and how what you've been discussing with us, how does that relate to Parkinson's disease dementia? If you could address that.
Yes. So as we shared, then Alzheimer's is characterized by the amyloid protein forming plaques and also the tau protein forming tangles. And there's brain changes and brain cell loss in regions of the brain affecting memory. And then that leads to that, symptoms including short-term memory problems. Parkinson's disease is characterized by changes to a different protein, so by alpha-synuclein protein forming Lewy bodies. Similarly to Alzheimer's, then this can also be accompanied by brain cell loss, and then it leads to loss of dopamine in the brain. And then crucially, then this is affecting brain regions which are responsible for movement. So then that leads to then a different, kind of profile of symptoms affecting movement changes. So you can see there's parallels there. So both are characterized by abnormal proteins, both have neurodegeneration or cell loss, but there's differences. So they differ in the key proteins, they differ in the brain regions where these pathology accumulates, and then as a result of those differences, they have differences in symptoms. Another parallel for them is that they're both progressive, so they get worse over time, and then as they progress, then there can be changes in other regions of the brain affected and a wider variety of symptoms. So for Alzheimer's disease, then it may not just affect memory and concentration, but also affect language, for example, and movement. For Parkinson's, then cognition can be further affected. So executive function can be affected, be effective early on. So then this is kind of multitasking and those types of tasks. And then as the disease progresses, 75% of people who have had Parkinson's disease for over 10 years in some studies then go on to develop Parkinson's disease dementia. So this is where these types of changes in cognition are meeting that level of severity to be interfering with their day-to-day lives. One thing I did want to highlight here is that mixed dementia is common. So between a third and a half of clinically diagnosed cases of Alzheimer's show at least some degree of Lewy body pathology at autopsy. Also, I'll just share another couple of stats. So it varies from study to study, but between 20 and 60% of people with Parkinson's disease dementia also have Alzheimer's pathology, so amyloid or tau in the brain. So there's some parallels, some differences, and then also some overlap between these different conditions.
Great, thank you so much. So just to highlight, you mentioned that amyloid therapies are now in the clinic, and just want to highlight that there are anti-alpha-synuclein therapies very similarly that are in research development, and that may very well be in the clinic should they proceed along the same pathway as the anti-amyloid therapies. So that's very exciting. So whereas amyloid and tau are the problem in Alzheimer's, and alpha-synuclein is a problem in Parkinson's disease. So we're hoping to sort of follow and hold on to the coattails of Alzheimer's disease and have similar therapies developed in the future for Parkinson's disease. So that's very exciting. And similarly with the biomarkers, you mentioned biomarkers for Alzheimer's disease. Parkinson's a little behind, but we also are developing biomarkers. So I think understanding how the Alzheimer's community is taking these advances, and then understanding that Parkinson's disease may be able to replicate that in our disease by learning what Alzheimer's disease has learned. So that's very, very exciting. And so we're very grateful to the Alzheimer's field and really excited to hear what's happening in your field. The next big question that has come up in the comments is people who are discussing their loved ones who have both Parkinson's disease and Alzheimer's, people who have gone to autopsy and had both changes in the brain. And so the question is, how often does that happen? And what are the challenges if somebody has both of those changes in the brain?
Yes, so then as I shared with some of those statistics, this is common where people can have more than one change in the brain. So then also that's not limited just to kind of the Alzheimer's pathology or alpha-synuclein pathology, but also there can be vascular changes in the brain as well. So all of these, can be present to greater or lesser effects. But what's great is that across the field, as you said, we're gaining a better insight into this biology. We're going from an understanding of disease which was centered around, the clinical symptoms, and where we could just, see there's these types of symptoms and kind of guess what could be causing them on the brain, to be having a more kind of biologically centered staging of these diseases, where we can see exactly what proteins there are, what accompanying changes there are, and then be working towards how we can be targeting those. So then this offers up a lot of potential, but then it is something that we're just seeing, continue to grow, continue to evolve in the field as a whole at the moment.
Okay, fantastic. Can we talk now about the terms Lewy body dementia and Parkinson's disease dementia? That confuses a lot of people. What is your take on how those terms are used, and how that is related to Alzheimer's disease?
Yes, so Lewy body dementia is an umbrella term, and it includes both Parkinson's disease and dementia with Lewy bodies. And both of these are characterized by alpha-synuclein protein in the brain. So they have that in common. What differs between these two then is what types of symptom emerges first. So with Parkinson's disease, then there can be the movement changes first, and then changes in cognition later in the disease course, whereas with dementia with Lewy bodies, then it can be the opposite way round, with cognitive changes first, and then it can be changes with movement later on. And these are tricky diagnoses to make. So then with the advent, we talked about with in the Alzheimer's field, just the advances we've seen in terms of, PET scans, in terms of also CSF tests and blood tests, that we can identify the amyloid and tau proteins. Similarly, we're seeing within the Parkinson's field and the alpha-synuclein field, advances in being able to measure alpha-synuclein, whether this be by PET or by blood tests. Now, these aren't ready, for prime time. They're not in the clinics yet, but they are in development, and they are going to be a game changer in being able to then aid early and accurate diagnosis, and also then be able to inform the development of new treatments. So ensure that the right people are enrolled in trials, and to be evaluating the success of these treatments in how they directly affect the brain.
Fantastic. So now my camera's working, which is great. So there was quite a bit of controversy around some of these amyloid antibodies that are not currently in use. Lecanemab is sort of a next generation that's now in the clinic. But prior to that, for a couple of years before, there was a bit of controversy around some of the medications about whether they should have been approved or not. Could you potentially talk a little bit about that controversy and what has been resolved about that controversy? And Jackie in our chat has asked a specific question about the safety of the actual antibodies being used. Could you maybe talk a little bit about how an antibody that's used in the clinic is created, and maybe resolve some of Jackie's concerns?
Yes. So first thing I wanted to kind of share that is just how historic these times are. These are firsts for the field. And then when we look at the firsts in other fields, when we're looking at treatments for cancer, in terms of treatments for HIV, it's not always been a completely smooth path. And that was the case in terms of, some of the treatments that we were seeing as these treatments emerged. But now we're able to see, not just from looking at one drug, but also multiple drugs, targeting amyloid in the brain. So both lecanemab and donanemab, these are extremely effective in removing amyloid from the brain. There's not really any debate around this. We can see the PET scans having amyloid at the start of the study, and then in the majority of participants, that amyloid can be cleared from the brain. then, so that's, a remarkable achievement. In terms of then the clinical implications, as I shared, these aren't a cure. So this is the first step. Alzheimer's is an extremely complex disease. It's characterized not just by amyloid, but also by tau. We can see other changes in the brain. These changes accumulate as the disease course progresses. So there's not one simple, cause of somebody's symptoms, and there's not going to be one simple cure. But these treatments are that important first step that can, make a difference today, and also can be opening the door to further treatments to make even a bigger difference tomorrow. In terms of side effects, then again, with any drug, it's important to be aware of the side effects and to be discussing them and to be seeing whether this treatment would be right for an individual, and that should be discussed with their doctor. So there are side effects. There can be, this drug is taken currently by infusion. There can be reactions to the infusion site, and then also there's amyloid-related imaging abnormalities can occur. So this is shortened to ARIA. So this is where there can be areas of swelling in the brain. And this can happen, and this is why then if somebody is administered this treatment, they're also administered a series of MRI scans. So this is so that then any types of incidents of ARIA can be detected and it can be monitored. So in the majority of cases, it can be that even if it's seen, it can be monitored and it can be managed. It is not accompanied by any symptoms, and somebody can stay on the treatment. In other cases, it may be then that if it's a bit more severe, that then the treatment can be paused. And there are cases which are rare where this can be fatal. So it is very important for people to be having a full discussion about possible side effects, but this is the case with many drugs. This is the case, when we're thinking about treatments for cancer, that everyone should be aware of potential side effects and then make the decision that is right for them.
Thank you very much. I think it's extremely important to highlight that we're at the very beginning of this. I mean, the burden of, as it's clear in the chat, the burden of dementia for many of the loved ones of the people on the chat is huge. And we've had such slow progress in trying to really crack this nut that these advances in a related dementia are just so huge for the Parkinson's community and for the Alzheimer's community. And it's not going to be a completely smooth ride. And we're going to have those bumps, as you mentioned. But saying that we have made some kind of progress has to be taken with just such gratitude, because there's been so little movement in the past number of decades, and so much struggle from these diseases. So we're eager for more to come. You have another comment?
No, and just to add to that, then just to kind of illustrate the excitement. So when the donanemab results were debuted at our conference last summer. So there was the presentation. We had thousands of people in the room. We also had some thousands of people watching online live. During the presentation, when they came to the results, the audience applauded in the middle of a presentation. Now that I've never really seen before at an academic conference, where in the middle of a presentation, people are breaking out into applause. So that just shows, how pivotal a moment it is, and the excitement that's in the field, not just for where we are now, but for where then we can go in future.
Absolutely. And so, just to, help the community listening understand how excited we are about these results, that we as the Parkinson's community can learn so many lessons from the Alzheimer's community because of all these advances that have been happening in the last couple of years. And we're very excited to, as I said, to piggyback, to hold on to the coattails, and to have therapies hopefully in the future that are going to be similar, to really help the people on the ground who are really suffering with these problems. And on that note, we get asked a lot So yeah, there's a lot of similarities between the different neurodegenerative diseases. So a lot of the diseases have, as you were talking about, abnormal proteins that are glumming up the system and causing trouble. So in Alzheimer's, it's, as we said, amyloid and tau. In Parkinson's and in Lewy body dementia, it's this Lewy body. A lot of people may have both. We've discussed all this. So there's a lot of similarities. We're heading in the same direction. And you mentioned a little bit at the end, but could you elaborate? How do scientists who work on Parkinson's and scientists who work on Alzheimer's, how do they talk to each other? How do we know what's going on so that we're not just doing the same thing in two different fields?
Yes, so we talk and we collaborate in a number of different ways, and often as well, it's the same researchers who are working on both conditions. So then I gave that example in the presentation of Oscar Hansen, who is a world lead in terms of the development of blood tests, and he's looking into the blood tests, not just for tau, for example, but also for alpha-synuclein. So they're using that expertise, across different diseases and different dementias. Also, our work at the Alzheimer's Association, we fund research into Parkinson's dementia, into dementia with Lewy bodies. We have networking events at our conference that we host in collaborations with others. We have a professional interest area which is dedicated to dementia with Lewy bodies. So we're really trying to bring the community together, and we're trying to do that the world over, and by making our work as inclusive as possible. So as I shared, we have our conference. This is hybrid. So it's not just the people who can attend in person, but if you're a Parkinson's disease researcher or clinician, you might not be interested in the, 4.5 days of content, but you can come to just those sessions remotely that are of most interest to you. Also, our membership society, iStart, we've widened access. We have free memberships for students, for anyone based in a low and middle income country. We have webinars throughout the year, which are free to view. So again, just trying to kind of break down barriers so that we can share the science the world over, and then by sharing that science we can spark those new ideas, spark those collaborations, and just accelerate progress in this field.
Fantastic. We're really at the end of our time, so I just wanted to highlight Greg's question, our last question from Greg Richer. So he is expressing frustration, $405 million for Alzheimer's research. Why is levodopa still the gold standard? So I hope after this conversation, we have addressed your questions. So one, we are aware that Alzheimer's disease has made advances, and we are right there trying to understand them and using that information to make sure that we do the same thing in Parkinson's disease. That's why Dr. Sexton is here today. So we're very, very much aware that we are following in Alzheimer's footsteps. We also have lots of money dedicated to Parkinson's research. And I am absolutely sure that just like Alzheimer's disease has lecanemab now in the clinic, we will have the next therapy in the clinic for Parkinson's disease as well. So we're all in there with you, Greg. The amount of money, I should mention, the amount of money to research is something that we advocate for constantly. And there's actually a national bill, you may be aware of this, a national bill in front of Congress right now that's going to establish a plan to end Parkinson's disease in a very similar way that a bill was on the table to eradicate Alzheimer's disease about a decade ago. Again, we're following. Parkinson's disease affects many fewer people than Alzheimer's, and therefore Alzheimer's did go first because they're just much more prevalent. Many more times the number of people in America have Alzheimer's and Parkinson's, and therefore they went first, but we're right there after them. So we are very grateful to the Alzheimer's community for setting a lot of these precedents, and very happy to be following in their footsteps. So on that note, I wanted to thank everybody for joining us today. And I really wanted to thank Dr. Sexton for that great information about Alzheimer's disease and really helping us understand what's happening in Alzheimer's disease, the excitement about what's happening in Alzheimer's disease, and understanding that Parkinson's can learn so much from Alzheimer's disease and copy that, so that we can make headway as well. Really, I wanted to thank you for joining us today. I wanted to thank everybody on our chat today for all your questions. We got to as many as we could. There was a lot of great talk in our chat, so I want to thank you for that as well. And if you missed today's program, or you came late, or you want to watch it again, it's going to be in our YouTube channel of momentarily, so please see it there. And then, of course, subscribe to our YouTube channel as well. For more information and resources about Parkinson's in general, please visit our website at apdaparkinson.org, and be sure to join us for our next Dr. Gilbert hosts on Monday, June 10th at 1 p.m. Eastern Standard Time. We're going to be joined by two experts in the medication management of Parkinson's disease, Dr. Stephanie Bissonnette, who is a movement disorder physician, as well as a person with Parkinson's. They're going to be helping us understand management of Parkinson's disease medications. So be sure to stick around for a few final messages. Again, I want to thank you for joining us today and for contributing all your very valuable thoughts. And we hope to see you soon on another APDA program. Have a great afternoon.
Hi, I'm Leslie Chambers, President and CEO of the American Parkinson Disease Association. Thank you so much for joining us today on our program. Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.